Hi, I'm Dr. Joe Rogers, President and CEO of the Texas Heart Institute. And I'm joined here today by Dr. Ryan Tedford from the Medical University of South Carolina, who just gave a terrific grand rounds at the Texas Heart Institute, really focused on using the right ventricle and pulmonary artery pressures to understand prognosis in patients with a variety of different conditions. And I know I've simplified that a little bit, but your description of the physiology and how you actually got to your observations was phenomenal. I'd recommend that people watching this segment actually spend some time going back and reviewing the grand rounds. And also I would just highlight that Dr. Tedford and his colleagues wrote a very masterful piece recently in the New England Journal of Medicine that really describes the complexity of the right ventricle and its relationship to the pulmonary arteries, the pulmonary vasculature, and the left heart.
Well, Joe, thank you so much for having me. It's been a real pleasure, and I always, of course, like to talk about the right ventricle. It's been a great journey. I've had a lot of wonderful mentors and colleagues along the way that have helped me, and I think understand the physiology then has, as you mentioned, allow us to hopefully understand disease conditions better, and not just in pulmonary arterial hypertension, but in patients with left heart disease and patients with left ventricular cyst devices. And so we're excited to continue to do more.
So one of the things I was very interested in your talk was this concept of right ventricular contractile reserve and its impact on outcomes. And I wonder if you wouldn't mind, just for those who haven't had a chance to watch Grand Rounds yet, just sort of reiterate this, what I thought was a really key concept. And it seems obvious, but because we don't measure it very well, and it's not something that's in our day-to-day work as cardiologists, we may not be thinking about how to approach that and what it means.
I'd be happy to. It's a concept that we are continuing to explore, but it makes a lot of sense, right? We do this in the left heart all the time. Patients with aortic stenosis, right? In the pseudo-aortic stenosis, how do we figure this out? Well, we give them dobutamine and look to see what happens to those gradients when the ventricular reserve increases. In our peripartum patients, right, can they get pregnant again? Sometimes we'll do a dobutamine stress test to look for evidence of reserve. And so it does kind of make sense that if we wanted to better categorize the function of the right ventricle, to look at reserve measurements, right? So reserve is simply defined as the ability of the ventricle to increase contractility at a given level of loading, so at a constant afterload. And we can do that with exercise, we can do that with dobutamine, and many times that may be very appropriate. And I think, again, there's emerging data that is prognostic in a number of different conditions, that it's helpful diagnostically. And so we can kind of continue to explore that possibility. We've looked at reserve a little bit differently when it comes to ventricular assist devices, because those patients are so sick. They can't exercise. They're probably already on dobutamine. And so we really kind of define reserve as what happens to the RV when you unload the LV, either pharmacologically or with a temporary device. And if the RV can't maintain LV preload, for example, then stroke volume, which is a systemic measure of function, is not going to increase. And so that's something that we're continuing to explore and toy around a little bit with. And I've seen now a couple papers to suggest that might be helpful in determining who is going to develop right heart failure after a ventricular assist device.
So I want to explore this a little bit more, because you presented some very interesting and compelling data, and I think you were talking about it in the context of your advanced heart failure population who couldn't exercise, and you were really focused on using systemic vasodilators to lower the pulmonary artery pressures. I think in the case you cited, it was sodium nitroprusside, and using that as another measure to improve RV contractility. And at least in the acute setting, in an ICU, you were able to demonstrate that it had prognostic value. Mm-hmm. What about taking that same kind of approach in a chronic ambulatory heart failure population? Should that be a target for us?
This is an area there's actually a lot of interest in it, right? So we're always complaining as heart failure docs, right? These patients arrive to us too late. They're too sick for some of our advanced therapies. And, we know that the RV is such an important prognostic indicator of advanced disease. But it's subtle, right? These patients can have occult RV dysfunction. And so one of the things we're working on now is how do we develop an RV stress test? So you have that patient in clinic who's doing okay, but are they really doing okay? Could we develop a stress test to say, wow, this RV is at risk, and before that RV falls apart, we need to get them to Baylor, to Texas Heart, to make sure they're not a candidate for some of these other therapies that we have to offer, as long as the RV is okay. So yeah, I think it could be a signal for us of when somebody needs more than just our traditional therapies.
So many of the people that will watch this segment will turn it off and go back to clinic. And they'll see a number of patients who are in their 70s and early 80s who have heart failure with preserved ejection fraction, and they come in with edema and elevated neck veins, and they've lost their appetite. What tests would you recommend for our colleagues out there to, in their office with an echo machine, to try to begin to understand right ventricular performance and the ability of the right ventricle to improve if the pharmacologic conditions and change the physiology sufficiently?
Yeah. You know, the RV is difficult to image, and there's a lot of limitations there. But I think there is pretty good data emerging now for what is some of the better surrogates that we have of the gold standard, which we talked about, which is pressure volume assessment, which is not going to be clinically feasible. So a lot of data actually out of Germany from the Gießen group, comparing these different metrics to our gold standard, they found really two that were probably the best. And one of those is the ratio of TAPSE to PAPSE, or pulmonary artery systolic pressure. So now, of course, that's not perfect because TAPSE is already a little bit load dependent, so you're almost correcting twice for load, but it does have a pretty good correlation. So if you have a good tricuspid regurgitation envelope and you can get a good estimate of PA pressures and you have a good TAPSE, that's probably one of the better echo parameters to assess right heart function. If you have the ability to do strain also has some load dependence, but probably, again, one of the stronger correlations to true ventricular function. So those are the two echo ones that I like to use the most. If you're doing right heart caths on patients, the PAPI, the pulmonary artery pulsatility index, the pulmonary pulse pressure divided by the right atrial pressure, seems to correlate best with RV function. You have to be a little bit careful with PAPSE, right, because that denominator is right atrial pressure. And if the right atrial pressure is low, then that number can be thrown off a little bit, right? So let's say you measure the right atrial pressure of 2 versus 4, that could make a difference twofold in the PAPI, even though there probably really isn't a clinically relevant difference there. So I think if the right atrial pressure is high, PAPI can be helpful. When it's low, I think all bets are off.
And Ryan, where's this field going to move? You know, you're a clinical trials guy. What's going to happen? What are the next trials that we might anticipate to help dissect this out a little bit more, or maybe to even begin testing specific pharmacotherapy that might influence right ventricular performance?
You know, I think as a field, when I'm speaking as a heart failure field, we really need to stop ignoring the RV. I mean, I think it's always referred to as the stepchild of the forgotten ventricle. I do think we're doing better, but we have to consider the RV in clinical trial design and as a part of the inclusion or exclusion criteria. And we really need to study drugs or therapies that might impact its overall function. And you know, there's some left heart failure drugs that might actually, physiologically, you could say, well, this really should impact RV function, but that's really never been looked at, right? And so I think we really should start doing that. I think the idea of earlier detection, I think we're going to see some in that field. You know, our patients with heart failure, looking at not just single snapshots, but longitudinal measures of right heart function, of hemodynamics, and perhaps developing some type of score or risk score to say, hey, this person's advancing heart failure. I need you to think about what other therapies there might be there. So I think those are kind of two areas that I would see us going.
Well, Ryan, listen, I wanted to just thank you so much for taking the day to come down to THI, spend time with us in Grand Rounds, and being so generous with your time and fielding all the questions afterwards. I know that the Grand Rounds was very well attended, and you had a remarkable number of people watching, online. So thanks again for taking the time.
Well, Joe, you know, I'm a Texan, so always happy to visit Texas, and I really appreciate the hospitality.
We'll have you back.
All right, very good.
Thanks very much.
Thanks.